Hi friends, this is M. Guru and today we will talk about the components of a safety checklist when you're about to do an intubation. An intubation is a very high risk procedure and you should ensure that there are things in order with a certain plan before a person proceeds on to do it. Now say example if this is the patient here, head, so the person who will be doing the intubation will be at the airway end and there is this person standing here at the foot end of the patient who is the team leader who, and from his perspective we will talk about what are the things that he needs to cross check and ensure are in order as you proceed. So before procedure, um, so there's things before procedure, then a timeout just before the procedure, then a plan, and then after you do the intubation. So in before procedure, the first bit is the patient optimization. So is the oxygenation okay? Have you sat the patient or are they getting full oxygenation? And checking the cardiovascular status that they have good IV access, and if they need any optimization of their blood pressure with vasopressors or fluid, because there's a tendency that blood pressure can drop during intubation when induction agents are given. Then GI, do you need to aspirate or do insert a nasogastral tube, and ensuring that they are in a good position there, which is like a sniffing position. So do you need to adjust the trolley, adjust their head end, so things like that. So patient, you have optimized the oxygenation, cardiovascular status, the GI and the position. Then next you talk about equipments and drugs. So check that the monitoring, including the EtCO2, your oxygenation, your heart rate, blood pressure, all should be showing on the monitor. Then you check all the airway equipment, such as your suction, which should be under pillow. So if the patient at the airway is here, so on his right hand side, there should be um, just under the patient, there should be the suction, which should be easily accessible to him. There should be the airway trolley where is immediately accessible, which contains all the airway equipment starting from basic to advanced airway. There should be water circuit with face mask, so that, and which should be attached to wall oxygen, so which will help you give the pre-oxygenation to the patient. Then that there are basic airway equipment such as girdle, nasopharyngeal airway is well prepared. And then you will go and talk about the drugs and dosage, and you should check for allergies. You should check the induction agents such as what is being used, which could be propofol, ketamine, and even some people use midazolam. So you could, the thing that will make the patient sleep. Then what sort of relaxant or muscle relaxant do you want to use? Is it rocuronium, vicuronium, or succinylcholine? And then you would want to think of any vasopressors. So some people may use metraminol. You may want to consider saline flushes, and you may want to consider fentanyl and other drugs, and what sedation you will use post intubation. So all these drugs need to be checked, and their doses also need to be kept ready. And what you would want to ideally do is load them in syringes and label them accordingly, so that you know how much drug is there in every syringe. So they are all prepared. So your patient, your equipment, and your drugs are loaded and prepared. Now we come to the timeout bit where the team tasks are allocated. So the person standing at the foot end who can see the entire process, it will be the team leader. The person who is at the head end is the first intubator, and then he will nominate a second intubator who stands, and if in the person is having trouble or cannot intubate, the person can help. Then you may have a CICO, means can't intubate, can't oxygenate rescuer, who will stand on patient's right and perform a laryngeal handshake. A laryngeal handshake is when you put your hands on the larynx to feel where it would be an optimal site to do a front of neck access in case if you land up in a position where you can't intubate and can't oxygenate the patient. An assistant who will be on the patient's right, who will be handing over the tube and any equipment that the intubator asks for. Now, lastly, you will check for drugs. They are confirm their drug doses. You may have an observer. Uh, so you may have an observer who is noting all of this. You can have help for cricoid pressure. You may have any medical information leaflets or things like that with you, and you should ensure that the senior doctor or nurse on the floor are aware that this process is going on in case help is needed, and they should know that they have so many staff deployed onto a patient. And you should always think that if this is a case and if this is a potential case of difficult airway, if you need to contact any senior anesthetists, ICU consultants, or any max fax or ENT doctors. So once you have all of these ready, now you proceed on to intubating the patient. But as you do that, you should before also have a set airway plan. How are you going to proceed? So the plan should be spoken up by the person who is doing the intubation. He should state his plan A, plan B, plan C, and plan D. And usually the plan A when you're going for advanced intubation is laryngoscopy, and you should have maximum of 3 attempts there before you declare failed intubation. Now laryngoscopy could be you could be using glidoscope or McGraths or video laryngoscopes. That depends on person to person, but you should also always ensure that the equipment is working well, and that of course goes on to um, in the first bit, that the lights and all are everything and cameras are all working. So your plan A is if you would go for laryngoscopy and you would intubate the patient under direct visualization. However, if despite 3 attempts in using any stillet or bougies and help, you can't, you declare failed intubation now, so that everyone moves on to the plan B or C, which is rescue oxygenation. That means you cannot get a tube into the patient, so you may use now face mask, along with OPA, oral pharyngeal airway or nasopharyngeal airways, or you may use an eye gel. And then you could think of what is the how long can you oxygenate and safely can you oxygenate them. If this also fails, and or if you are unable to oxygenate the patient using your eye gel or face mask, you will now declare can't intubate, can't oxygenate. This is a CICO condition where now in order to salvage the patient, you will need to go on to the plan D, which is the front of neck access, where you extend neck and and you would get, basically you need a scalpel, bougie, and a size 6 tube along with suction to ensure that you are putting a tube through the cricothyroid membrane and getting and able to ventilate the patient. So anyways, your airway plan should be clear and everybody should be on the same page. So you've ensured before procedure and timeout and the plan, and you intubate the patient. Now after intubating the patient, uh, then once you have seen that the tube has passed through the vocal cords, immediately you would want the EtCO2 and confirming that the patient's oxygenation and EtCO2 is shown on the monitor. You should be able to see that, confirm, ask someone to put a stethoscope and appreciate that he is getting good air entry on both the sides. Then you should look at the ventilator settings, adjust the tidal volume uh, around 6 ml per kg. You may want to have mandatory ventilation in the, like, pressure control or volume control in the beginning, and you may want to have FiO2 enough to keep the oxygenation SpO2 at 100%. So you would initially go with highest ventilator settings. You would then move on to getting the sedation and vasopressors, all those things, whether it is propofol or whatever infusion, in order to keep the patient sedated, and think whether the muscle relaxation needs to continue. A nasogastric tube needs to be inserted. You should definitely request a chest x-ray and document any drugs and the procedure, and then you sign out. So this is how a safety checklist for an intubation should be performed. See you in the next video. Thank you.